Is it live? It has been the whole time. What's up? What's up? Good morning, everybody. Good news. There's nobody viewing yet anyway, Bailey, so it didn't matter. So Dr. Emmett here from Las Vegas. We have a live event that starts in 4 minutes, and we have a very special guest today. So we're a few minutes early. We're just going to get Dr. Mike Stanley from Georgia queued in with us here. And in case you don't already know this, it's Halloween. Happy Halloween. And that is also the explanation for why all of Las Vegas is completely shut down, because it's Nevada Day here in Las Vegas. So schools are closed, pretty much everything else is closed, including all the podcast studios. So we're coming to you live from beautiful All Out Dental Broadcasting Studio in downtown Las Vegas. That's my own office. That's what all that means.
We are not in downtown Las Vegas.
Not even downtown Summerlin. North Summerlin.
Yeah,
we can't say downtown Las Vegas. That's true. We are in a suburb of Las Vegas called Summerlin, and we are on the north end of Summerlin, almost to what's the next north area? Not North Las Vegas, because we're too far west.
we're just in Summerlin.
We're just in Summerlin. We're in Summerlin. That's just it. It'll be fine.
I'm not that great with directions,
We're
so
up on Insta, Facebook, and
All right, so we are up on all the platforms. Insta, Facebook, YouTube, all the places we're supposed to be. Big shout out to the media team for getting this set up here at the office. This is just a sneak peek of the consultation room. If you ever come in for a consultation here in Las Vegas, this is the consultation room. I'll give you a tour, but if I move this computer around and mess up where they've got it all set up, I'm going to get in trouble. But there's a desk over there. There's a chair right there so we can do an exam. There's a big screen up there that we look at your x-ray together. Yeah, that's about it. We'll make a video. Daisy said we'll make a video. There's a really nice carpet. There's some nice chairs. Should I stop talking about the office? All right. So they are just working on getting Dr. Mike Stanley patched in. Again, we're still a few minutes early. We'll go live right at 9 o'clock. I don't want to talk too much about Dr. Stanley. A, I don't want to make his head too big, but B, I just want him to come on the call and introduce himself and say what he wants to about himself. So I won't say too much, but I will, spoiler alert, tell you we have a long list of questions that have been submitted that we plan on answering today, and we have a lot to talk about. So we're really excited to get started. I just saw a notification that says Dr. Mike Stanley entered the studio. There he is, Dr. Mike Stanley.
In the studio.
In the hat. Dude, you wore a hat. That was really good. You're so trendy and youthful with your hat. Oh my God.
Oh man. I love to be trendy.
You're looking good, bro.
When you have a face like mine, you got to have accessories. When you have a face like yours, you just look good.
Dude, stop it. You're so funny. Oh, dude. He just dropped us off the table.
Mike Stanley out of the studio.
Mike Stanley has come in and Mike Stanley has left, just like that. Quick, just like that. So we'll probably wait for another minute here before we get started. What's on? Is there a tooth on your shirt too?
Oh, we got Timber Ridge.
Oh, you're repping the office. That's really smart, man. That's
Timber
good.
Ridge.
That's really smart. Is your hat Timber Ridge too?
No. The Timber Ridge is actually axe throwing.
Oh.
In Memphis, it's the only, actually, I would say the only interesting thing to do if you're in Memphis is go axe throw. But you have to drive around the right way, because if you go the wrong direction, you're going to walk through two very dark, very scary passageways, and you may come out with one hat less.
You sound like you have some personal experience doing that.
Man, it was a great time in Memphis. And I'm glad that I live in Atlanta. Let's just say that.
No, that's cool. So, but you just talked about where you live. So real quick, let's get started. It's 9 o'clock in the morning, Pacific time. So it's noon where you're at, right?
Noon. The day's already halfway gone here.
Yeah. And spoiler alert for everybody, today's Halloween. And my staff just said, you should have dressed up. And I was like, I didn't even think about that. So yeah, we probably should have dressed up. I don't know. But yeah, today's Halloween. Pretty much all of Las Vegas is closed today because it's also Nevada Day. So all the schools are closed. They celebrated Halloween yesterday at all the schools. So It's Nevada Day here in Nevada. So anyway, So super excited. We've got Dr. Mike Stanley here. And what I'd like to do first is if you just want to take a couple minutes, introduce yourself, tell us where you're from, where you practice, tell us a little bit about your practice. I think the spoiler alert is obvious that you're a 3-on-6 provider. And that's why most people are here for this call, obviously. But why don't you take a few minutes, introduce yourself, and tell us a little bit about your practice.
Yep. Thanks, Dr. Emmett. We have a 3-on-6 specific office. We also do general dentistry at the office. I've got 2 doctors that work with me, 2 of my good friends in Dawsonville, Georgia. So you go from Atlanta, head north on 400 and right near the outlet malls. It's about an hour from the airport. So we do have patients that have flown in to do treatment. We've got a couple of recommendable hotels and a couple to avoid. So call the office before you book.
We do the same thing here.
Yep, same thing. I'm sure you guys do the same thing. I know you guys have patients that fly in there as well. So you use the team. So, yep, I've been graduated from dental school just over 10 years ago and looked for an implant option. I was blessed to go to Midwestern in Arizona where we didn't have a lot of specialty programs. So we got to do a lot of the dental work. We didn't have oral surgery or perio or any of these people taking some of the cases, which as a patient, you might not know that, but like it's important that you get experience. So I did a full mouth implant case while I was in dental school. Back then we did it a lot differently than nowadays. It was goopy impressions. It was stone models. It was wax. It was
old school.
It was almost my whole clinical experience. So we took we had the patient.
One case. You graduated dental school.
Yeah. It was almost enough criteria to do it. I mean, we took out all of his teeth. We grafted. We gave him dentures. Then we did impressions, and then we waited, 3 or 6 months. Then we did his planning and placed the implants. Let those heal under the dentures.
Oh, wow.
And then we uncovered everything and attached the implants to the connectors. And it was, I had a great lab that I worked with, but it was analog. Everything, there was no digital like we do nowadays. You and I are blessed to work in a time where we can predictably do the dentistry and plan it online. I mean, we plan it before we even do the case. We know more or less how it's going to go. So anyways, did that in dental school. And I looked for so many years, how do I find an opportunity to do this again, but better and in my own practice? So was able to find 3-on-6, went and did there. And the biggest thing, it was just a great lab, great flow, great support from other doctors. I mean, when you're undertaking something like this, as you well know, you're the only doc in your office. The buck stops with you. And in residency programs and other places, they can roll onto someone else and say, "Oh, this is too hard for me. Let someone else do it." We do it. And so, anyways, that's been a huge blessing to just kind of get everything settled in Georgia at Timber Ridge. We've had a great reception in the last few years and gotten very good systems down. And I'm happy to be offering 3-on-6 to patients and talking to them. We've had just a plethora of happy patients. And I try to explain before it happens what's going to happen. And so we see into the future with our little crystal ball. And, not everything goes perfect every time, but we really do try. And it's no matter what we do, it's better than the alternatives that we were doing years ago, which was all on 4, all on X. If you're a candidate for it, 3-on-6 it's just obvious. It's the best option.
Yeah. Man, I appreciate you sharing that. Your enthusiasm for 3-on-6 comes through, and I love that. Yesterday, I was making a video on the way to work, and I just love my job. And it's not because everything goes perfect every day. It's not because everything's always easy, but man, 3-on-6 is amazing. And what we do for patients is amazing. These patients, literally, a lady left my office the other day and couldn't stop smiling, like literally could not stop smiling. And she's just in her second set of temporaries, but it's life-changing.
It is. That's one of the things when I first met you, that was what I loved about you as well. Like we hit it off really well. We got enthusiasm for what we do. We don't, in general, I don't have to do this. I could work at Home Depot and be fairly happy. I mean, I could. I like people. I like helping people. But when you see the smile on someone's face in the end, and that if they had done all on 4, or if they had done a different option, it would not have gone as well. It
Right.
just brings pride in your heart for our profession that we have to have people putting the effort in to do what we're doing and carrying that baton, I guess we could say.
Yeah, that's perfect, man. That's a great introduction. I think it's fun. One of the reasons I thought, man, we should do a call with Dr. Stanley is because if you go to the 3-on-6 Facebook page, and I'll admit, you even answer more questions than I do. Like, you're the GOAT when it comes to replying to patients and answering all the questions. But it's typically you and me or the doctors that are chiming in and answering questions. But there's an interesting thing that happens, and I've noticed this with you too. It's not my patients. My patients are so educated and they're so prepared. It's not even my patients asking the questions. And the same thing with you. Now, a few will trickle through of my own patients. That's fine. But most of the time, we're answering questions for patients who, A, aren't even a patient yet, or B, are a patient of another doctor. And they don't know where else to turn, and they go to the 3-on-6 group. So they see our names pop up a lot over there.
Yeah, I think I found value in it as well. It's one avenue where I can feel pride in being able to just answer some questions, alleviate some anxiety, because that's really what it is. Almost all of the time, the questions are not a concern. It's going to be fine. You're going to be okay. And a lot of patients need that reassurance of, hey, this is the process that's going to be going forward. Maybe there might be some complications that happen. I mean, all of these cases are extreme. The most difficult cases that are in dentistry are what we're doing. There's nothing more, unless you're entering like the hospital setting of oral surgery and breaking someone's upper jaw. And I mean, that's the only thing that is more technical than what we're doing. It's just, you combine that with the technology, there's nothing harder. So they need that.
Well said. So the topic for our event today is the 3-on-6 procedure, what to expect on surgery day. But we also are just going to talk about all things related to 3-on-6 and then answer questions as they come through. And then we have a whole list of questions today that I want to get to if we can. So for starters, I think we should just talk about what happens on surgery day for the patient, maybe a little bit of what their experience is like. I'll start and just talk a little bit about what we do here at my office, and then I want you to kind of talk about what you do at your office, because there may be some differences there, and we've never even discussed this before. So we start pretty early in the morning. We have my patients get here by 6:20, 6:30 in the morning, and we want to have them sedated and ready to go by 7 a.m. So when the patient gets here, I walk out in the waiting room, I talk to them for just a couple of minutes, I review their treatment plan, I just make sure they know what to expect for today. I always ask them the trick question, what'd you have for breakfast? We got to make sure they've had nothing to eat or drink since last night. And then they get right to the anesthesiologist. So then the anesthesiologist comes up front, talks to them for a few minutes, goes over their paperwork. And the next thing is we're bringing them back into the room. Once we get them into the room, we get the IV started. I pop back in the room real quick and do what's called a surgical timeout. So I just make sure we have the right patient in the chair, having the right thing done, pretty standard. And then that's it. That's all the patient's going to remember. They're going to go right to sleep, have a great nap, and everything else, the injections, the extractions, the implants, it all happens after they're asleep. And then once the procedure's finished, we wake them up, get them ready to go home. And I tell them, I'll tell you how surgery went. I'll let you know. You're never going to remember. You'll have no idea. We're going to send you home, but tomorrow when I see you, we'll go over all the details. And we just get them back the next day for a quick post-op. We take an x-ray. I do some bite adjustments, make sure their bite's nice and locked in for them. And that's pretty much the process from a 30,000-foot view of how we do it here in Las Vegas. How about you guys?
Yeah, it's almost the exact same. Early in the morning start, we want to get those patients in 6:45 and get going on sedation. We draw blood, use that and mix it with bone graft to be able to get the results that we want for socket preservation and just build back that bone. A lot of as the comparison between drilling away bone and grafting bone, we all try to preserve as much as possible. But patients will get there. I always talk to the driver, whoever's taking care of them, and even after the patient goes back and the anesthesiologist takes them back with the team, I stay out and talk to the driver for just a second to give them a little bit more personal information. This is what I want you to watch out for. These are the reasons why you might be concerned. If there's excessive bleeding, if there's a little oozing here and there throughout the day, the evening, through the night. That's very normal. If the patient says that it's tight, you can't let them, I always joke and, tell them, hey, you can't let them make any big decisions. No getting married, no getting divorced, no having babies, no selling your house, no signing your rights over, nothing. And, but yeah, so then next morning, see them, same thing, check the bite. It's really important that the bite is adjusted the next morning, really well, because we want all those implants to get distributed forces across, as opposed to one implant getting hit harder than the other ones. That can cause an issue, especially if a patient's not paying close attention. And I think you and I both do the same thing. We very detailed drill it into our patients, not in a traumatizing way, but in a, like, I'm trying to scare you into obedience because I want to have the best outcome possible. And I think that contributes to a lower failure rate. The higher education, I say the higher dental IQ we can get a patient to have, the lower would be our risk for failures and poor outcomes, that kind of stuff.
Yeah. That's very well said. So I love that you spent some time with the caretaker. That's so valuable. I do something similar. I just do it at the end of the case when they come in to pick them up. I go spend a few minutes with them, go over what they need to know. We give them a little pamphlet and we give them a bag. And in the bag, we give them stuff like mashed potatoes and applesauce and a protein shake. And we give them some stuff like, hey, when you get home, here's the foods they can eat. There's a whole list of when to take your medication, how to take it, because there just seems to be so much confusion about that. So we just try to over-educate. I just want to give you more information than you possibly need right now.
Yeah, that's about the same. We have a backpack, give them a backpack and some info on it. That's a great idea, is to add some possible food. It's like, hey, these are recommendable foods. You can get different brands, different things, but you don't put a bag of Doritos in there. I guarantee you that.
No. And I'm always have this fear in the back of my head that a patient would get home and be like, oh, crud, I didn't get anything I can eat, and then eat the wrong thing or not have something at home that's easy for them to eat the day of surgery.
Yeah, so, I had a patient come in the next morning for a bite check, and I found a sesame seed. And I was like, what's going on, buddy? And he's like, oh, no big deal. It must have been from the Arby's sandwich I was chomping on last night. These things are great. And I was like, no, sir. Do a little one of these right here. Like, no, sir. So it was good for him that he did have some signs that he wasn't going to take care of it perfectly, because it gave me the time to reinforce and say, hey, this is not going to help you. It's going to cause problems for you in the future. Don't do this or else, that kind of stuff.
Yeah. I talk all the time about pizza is the #1 bridge killer. And this lady comes in just a couple of weeks ago, swear on my life. And I'm like, hey, so have you been on the soft food diet? She's like, oh, absolutely. Yesterday, all I had was pizza. And I'm like, again, that is not a soft food. Can you cut that with a plastic fork? So yeah, it does create a pathway for some more education, because that soft food diet is so imperative for success. And that brings up one of our first questions we have today. I'm just going to read this question, and then I'm going to let you take the first go at it, and I'll go after you. So
sounds good.
Jennifer just asked, she said, I think I know the answer, but are there any signs of an implant failure? I'm a Dr. Locke patient in my temps, and y'all know sometimes we freak out. Yes, we know.
Yes, we know.
Also, I want to tell all of the providers that you are true healers. I love that you all help each other. Super cool. That is one of the nice things about the 3-on-6 provider is we are really well supported and no ego involved group of doctors. And I love that too. So anyway, I'll let you take the question.
So Jennifer,
are there signs of an implant failure?
Yeah. So, Jennifer, that's a pretty common question. Everybody wants to know. And so some guidelines are, there's two distinctions. We have an early failure and a late failure. An early failure would be if for 3 or 4 days, you're going to be increasing your swelling and pain. And, for 3 or 4 days, it may get a little worse for the surgery portion. We always say peak day for swelling and pain is 3 or 4. But after that, things should start to get better. And we talk about like a scale going up and down. So as it goes down and down and down, it gets easier to deal with, less discomfort, all those kind of things. If one area is increasing and going counter to the others after a week, 2 weeks, something like that, that's when, you may indicate that there could be a single failure. Normally it's not a multi-failure. I mean, I haven't had very many patients in fact, I haven't had a patient have multiple failures on the same patient. So it's usually a single point failure from either a site that was already infected, and that bacteria we try to clean out as much as possible, scrape it out, clean it out, and then get the implant in the correct location. But if there's a bump on the gums on the outside, that's a pretty good indicator.
Yep.
But that pain going counter to the rest of your mouth. Hey, the right side feels pretty good. I mean, when I touch it, it feels pretty normal. But this one right here, it feels weird and strange, and it's getting worse.
Yeah.
I call your office and absolutely say, let them know, and they may say, hey, let's give it another week, a couple of days. Is it tolerable? Is it not? A lot of that's dependent on the patient. But then the other one is going to be the late failure. A lot of patients don't even know that and a lot of times we don't even know. I look at it and the x-ray looks okay.
Yep.
We take the temporaries off. The gums are pink and healthy around it. So we torque test every implant. We, make sure that, and I explain it to patients as it changes from drywall to a stud. So when we put it in, it's kind of like a drywall screw, and you can remove those, and it's, it's kind of it's in there, but it's not, you don't want to hang on it. But after 3 months, it becomes a stud screw where you can do whatever you need to, but we need to check that first. And if I start to reverse that implant and it just unscrews, we can either immediately go back into the same site, different site, and place it, or in certain cases, if there's not a lot of bone to begin with, then we would need to graft and come back at a later date. But I will say the benefit to the 3-on-6 is even if you have a single implant failure, you very rarely, I've only heard of one, maybe 2 instances where a patient would leave without their teeth in place, and that's like a huge rarity that would ever happen. You can
always difference between this and an all-on-X, because we have 6 implants in there. If one fails, it's disappointing, but it's not the end of the world. We need 4. We have 2 spares sometimes.
Yeah. That's a huge benefit, especially during that healing time. And then that next implant, when it's going in, it's going to have 5 more implants that are fully integrated supporting it. So it has even a higher incidence of success. So, I've had one patient that had a failure and then a failure, and that was tough for the patient. But you just persevere, and we're going into a very difficult situation to try and remedy a problem that was pretty substantial to begin with. But that would be my advice, Jennifer, is pay attention to bump on the gums or pain that is not coincidental with the rest of the teeth.
Yeah, I would say the exact same thing. If you can isolate it, you can tell me it's right here that doesn't feel good, I'm going to have you come into the office. If you say, yeah, I'm just sore, my bottom jaw is sore, the top sore, that's normal. But when you can isolate one place and you can touch it and say, that's where it hurts. First off, if it's in the first 2 weeks, yep, that hurts. If it's in the first 3 weeks, even, I'd say, yeah, let's be patient with it. If it's persistent beyond that, stop by the office. Let's take an x-ray. Sometimes the x-ray will tell us some of the picture. And if that's not giving us all the picture, let's just take a look in your mouth and see what's happening. So is an implant failure, are there any signs? There are, but they're not traditionally what the patients think. Patients all the time are like, I think I'm having an implant failure. And I'm like, nope, that's not the symptom. But I don't tell patients the symptoms of failure, because then magically that's in their head. So they're worried that that's what's going to happen the whole time.
That's a good point.
One thing that Dr. Stanley brings up, which is very valid, is most of the time, future down the road implant failure, the patient doesn't even know. It's not painful. It's just an implant that didn't integrate into the bone. And sometimes I'll start messing with it, and that implant will come out, and the patient doesn't even know I'm taking it out.
Yeah,
because it's not traditionally a very painful experience. So she just said, thank you. I think a lot of patients don't understand how complex this procedure is. Y'all are performing miracles. I mean, yeah, kind of. Yeah, they're miracles.
I was gonna say Vegas has been, Vegas needs some miracles.
We need some miracles out here. So yeah. Anyway, good question, Jennifer. Thanks for asking. Okay, so let's go to the list real quick. I want to spend a few minutes and talk about patient selection. We get patients in the practice every day, and they say, how do I know I'm a candidate? How do I know I'm not a candidate? Is there a way I can tell I'm not a candidate? So I just thought if we each just took a few minutes and just globally addressed patient selection.
Yeah.
and we can talk about health history stuff. We can talk about bone height and clinical presentation stuff. So let's just take a few minutes and talk about patient selection.
Patient selections. Yeah, I'd
and
love to
who
hear.
is or isn't a candidate. So do you
Okay.
why don't you go?
Okay, yeah, that's fine. A lot of times we both offer virtual consultations. So
That's true.
if you have a panoramic image, which is a 2D, it doesn't give us the three-dimensional area and shape of your bone, but it gives us a good idea. Many times we can give you a good indicator as to whether you're a good candidate or not. If you have a lot of your teeth still there, but they're broken down, it's a great indicator that you're a wonderful patient. That's
Yeah.
probably the best patient is what we call terminal dentition, meaning you've got most or all of your teeth.
How do you say all the exact words that I say? We've never even talked about this, and you're
Really?
thousands of miles away. Dude, this is exactly what I say every time.
That's great.
Yeah, keep
Hey,
going.
great
It's
minds,
great.
great minds. But when you have the end of the road for those teeth, we can't crown them anymore. There's not enough tooth to do a bridge and gums and all that, but all the bone structure is still available. That's the perfect 3-on-6 patient. Someone who's had a bunch of traumatic extractions over the years, never did any bone grafting, and they've got 1 or 2 teeth left and a partial that they've been using for 15, 20 years. Those are more difficult, and a lot of times we can still do and I call it a 3-on-6-esque prosthetic, which is that it's shaped similarly where it goes into the gums, so it's easier to cleanse. It's more tissue friendly than something like a denture resting on top bolted to implants.
Yep.
But then the prosthetic, when you pull the lip back, it can look like the teeth are really long. A lot of times people's smile accommodates that perfectly. And even if we add pink acrylic to something, it can still be a 3-on-6-esque or a 3-on-6 like prosthetic without being a bulky all-on-4. So
Yeah.
Even if someone has told you, hey, you can't have an FP1 or a 3-on-6, and we can only do all-on-4 on you, and we got to grind away more bone, you should still contact a 3-on-6 provider, because if I was getting the procedure, I would find someone who knew how to do what we're doing to do the other, because I still want it to be as slender as possible. So yeah.
Good point.
Yep.
So for patient selection, we do the same thing, consultation, and just what you said. If there's existing teeth there that are broken down, there's typically enough bone height. That's a really encouraging sign for us that we have enough bone there to do a full 3-on-6. There's some things I look for in a health history. So I think, in fact, yesterday I had a really challenging conversation with a prospective patient, because in the health history, when somebody's smoking 2 packs of cigarettes a day, what does that do to your mentality about the case? And I'll tell you mine first, then you can say yours. I keep making you go first, but
you're good.
There is really strong literature that supports that implants will fail if the patient is smoking. And it doesn't mean they're all going to fail. It doesn't mean they have to fail, but it just means they could. And there's a risk. The best patient, the best bone, the best surgeon, the best implant, that can still have a failure. And if we're doing something like smoking, we're going to increase those risks. And even if the risk is small, you're getting 12 implants. So even a small risk, there's a risk now that we're going to have one of these fail because of the smoking. It's a big deterrent for me, because I've had a bad experience. We had a patient that said they would stop. They didn't stop. They had multiple failures. It's an interesting question, because I go and I teach I'm a mentor from some other courses. And one of the courses I teach is how to extract third molars. And my favorite, so I always have to pick a demo patient. And there's doctors lined up in the room, shoulder to shoulder. There's a screen, there's a film crew. They're watching me do the surgery. And I purposefully pick a smoking patient, because when I make the incision, no blood comes out. It's such an easy case to see. But that's a true statement for my 3-on-6 patients. I make an incision, there's not that much blood. But that's a problem, because that's where all the healing things come from. Your blood brings the healing components to make that implant heal, to make your gum tissue heal. And if you have decreased blood flow because you have vasoconstriction from nicotine, we just run the risk of having failure. So when I look at the health history, I of course look at their meds, I look at all that other stuff, but I also look really careful at the smoking and the poorly controlled diabetes, because those 2 things alone increase risks, and obviously together they can create some major risks for implant failure.
Yeah.
How do you feel about smoking?
Yeah, so if a patient is chronically smoking and has diabetes, uncontrolled diabetes, you know, I'm not going to do it in front of them, but we're going to talk about their little lifetime warranty. There's not one of those, because there's just essentially, I'm willing to do a surgery on someone because we've had success. I've done lots of implants on smoking patients, and they've done okay. We've had a good success rate. But the ones that fail, it's traumatizing to a patient. It's demoralizing because you're spending a lot of money, and it's just not the situation that you want. I don't want to have a patient with failures because I like happy patients.
Yeah.
We are traumatized as dentists by people saying they hate us. So
That's true. Yeah.
So we're trying to break that script. So the only thing I would add to that is a smoking patient, very, very, very important to mitigate those risks. If you're not taking, some supplementation, if you're not getting enough calcium, that kind of thing is important. If you have uncontrolled diabetes, you're not going to heal as well. It's going to be more painful. People with a lot of stomach and bowel issues that can't take medications afterwards can experience more pain.
Yeah.
Hey, I can't take ibuprofen. Hey, I can't take this. I can't take that. So taking into consideration that beforehand, a lot of times our anesthesiologists are able to give some really good medications through the IV, which really pushes people through that first wave of pain.
Right.
We probably more than any of the other implant surgeons experience patients that say, I never had pain. I never
All
had
the time. I try
all
to
the
tell
time.
people all the time. Patients will come in and say, I never had any pain. Like, I feel
Yeah.
better now than I did before I had the surgery. I feel way better.
Well, we can't guarantee that. And I literally will never guarantee that to a patient,
Yep.
because we have many that do experience pain and have to deal with that. More times than not, it's the stitches that are more painful than anything.
Yeah.
And I just had a guy call last week. He's like, we need to get these stitches out. Can we get them out, please?
Yeah.
And as soon as we took him out, he's like, oh my gosh, that feels so much better. But initially he called and said, I'm in pain. And I'm thinking, oh man, I hope it's not something terrible, but it's stitches.
Yeah.
The other thing is going to be patients with osteoporosis medications. So
Yeah.
you mentioned patients that don't bleed. When you're on a bisphosphonate, or, I've had a patient that came in and they were like, my doctor just told me that if I have any dental concerns, I need to get them taken care of because they want to put me on Zometa or, some of the bisphosphonate therapy. And I said,
Yeah.
well, we need to get your implants in and
Now.
healed and integrated now. So we're going to do the surgery before she starts her bisphosphonate therapy. And usually that's that demographic of a middle to older female that is going to be in the osteopenia, osteoporosis demographic. So if you're considering implants, or if you're trying to figure out your timing, make sure if you are at the risk of having low bone density, you need to talk about that, because the osteoporosis medications will stay in your body for 10 years, even if you take it for one. I mean, it's going to be in there for a long time. It
Right.
reduces the blood flow to your bones. It reduces the amount of cells that are breaking down your bone and building your bone every single day. All of us, in all of our bone, it's
Yep.
getting remodeled every day, in and out, taking away, putting in, builders and breakers. And if you kill all the bone breaker cells, those osteocytes, you're not going to have the same blood flow to those areas. So if the bone dies around an implant, the implant's going to fail. I mean, that's just because the bone died. So be careful in that situation too. But I think those are pretty big red flags for people that are trying to get all implants, is just like what you said: smoking, diabetes, and osteoporosis medication.
I'm glad you brought that up. So it's kind of a segue to a question we got just a minute ago. A patient, or not patient, somebody named Joseph asked, he said, I'm concerned I'm not getting anything for pain, just ibuprofen and Tylenol that barely cures my headache. I'm going to just take a stab at this. I'll let you take a stab at it. In my practice, I do prescribe a narcotic while my patients are recovering. We put them on a little bit of Norco, give them a couple of days of that. And it's not required. It's just so they have it if they have some breakthrough pain. But I will also say that ibuprofen and Tylenol taken together, taken the way I tell you to take them, which is 800 milligrams of ibuprofen plus 1,000 milligrams of Tylenol every 6 hours. If you take it that way, that is most of the time, I don't know a percentage, but by far most of the time, sufficient pain management for a 3-on-6 procedure.
Yeah.
So that's what we do for now. If somebody's having breakthrough pain or unique pain, I'm going to get more involved. I have some more stuff I can do. We have some things we can do to help.
Yeah.
But good icing for the first 36 to 48 hours, plus ibuprofen and Tylenol, you're going to have traditionally some really good pain management from that. So why don't you speak a little bit to your post-op pain management?
We use the same terminology. Breakthrough pain is going to be, something that's abnormal. And we always say staying ahead of pain before you try to catch up. So
yeah,
I made a protocol sheet that I give to every patient with times of the day and dosages and alternating. So I'll tell Joseph the backstory behind this. I was a military dentist when I first got out of dental school, and in the military, unfortunately, we as medical professionals, doctors and dentists, contributed to the opioid epidemic tremendously. We gave those things out like narcotics were candy. Wisdom tooth case, we'd give 20, 30, and the Marines that I was working on, we did not do them a favor by doing that because we weren't looking into the research enough. So there was a huge push in the 2010s, 12s, 15s, something like that, to avoid opioids. And as a result, there was a bunch of research that was done. And mine is almost exactly what Dr. Emmett's is, but we will do directly at the end of surgery, the anesthesiologist will give a Toradol injection or a shot through in the IV, which basically liquid Tylenol. And it's it's going to last for quite a while. It's more effective than the pills because it's not absorbed into your stomach. It's directly into your veins. Then they'll give a steroid as well. Steroids, we talk about non-steroid anti-inflammatories, and there are steroid anti-inflammatories. So we use both. So they get a injection at the end that typically carries somebody through that evening. We do tell them the next dose and the time that they should take their next dose, and they start with ibuprofen after that. So we will do 800 of ibuprofen, just like you said, and then 4 hours later they'll take 1,000 of ibuprofen, and then 1,000 of Tylenol. Then 4 hours later, the 800 of ibuprofen, and they rotate back and forth, back and forth. Now, we will give some narcotics, like I'll give maybe 6 or 8 Norco pills. We call them rescue pills, and we call them a replacement for one of the Tylenol. So most people know that Norco has Tylenol in it. It has a little bit of Tylenol in it. So what we'll do is ask you, if it's 2 o'clock in the morning and you're up for your Tylenol dose, and you're having a pretty good bit of pain, you're not thinking you're going to get back to sleep, take one of the Tylenol away, take the other Norco with it. So 2 o'clock in the morning, if it's coming around, you'll take one of the 500s of Tylenol and then one Norco, which will give you 825 milligrams of Tylenol plus the narcotic. And that helps that breakthrough pain, so that the next round at 4 hours, you can take your ibuprofen, stay ahead of that pain. But we don't drop the ibuprofen Tylenol to start a narcotic because it doesn't last. So that's the adaptation that we found, and for the vast majority, it's enough. And for those that it's not, we definitely, you got to call the office and come in, and we'll write the prescription for some Norco, something like that, to add in there. But yeah,
we do very similar. That's interesting that we're on the same wavelength there. That's wonderful. So we're about halfway through the live event. So what I want to do is I want to just take just a second here and just, we've had people join us. We'll probably have people watch this and not be from the very beginning. So I'm Dr. Emmett. I'm a 3-on-6 provider in Las Vegas, Nevada. And at my office, this is all we do. We are just a 3-on-6 office. And so if I have a patient that's calling or reaching out to us from across the country, I always say, I recommend you go to the nearest provider. Now, that being said, over half my patients fly in from across the country to see us. And I'm really grateful for that. It's really a wonderful thing. But we are in Las Vegas. And then we've got Dr. Mike Stanley with us today. And you are where?
Yep. So I'm I'm close to Atlanta, Georgia, so Dawsonville, Georgia. And we're, same vein. Dr. Emmett and I are in the same vein that when we hear patients, talking about this, it would be best for you, most likely, to see your nearest provider for any follow-ups, complications, and issues like that.
Yeah.
However, we do have patients fly. Most of ours come from the South, North Carolina, South Carolina, Tennessee, Alabama, Mississippi, some from Florida, but we've got some great providers in Florida. So, there's a Dr. Osmond that's there. So great people there. But yeah, we have had some patients fly from farther away. And I've actually, anytime somebody flies in from far away, I get on a virtual conversation with them and I ask them, are you sure that you want to fly here? I'm happy to see you, but are you sure?
Yeah.
Because anytime somebody all of the hundreds of patients that fly here from Las Vegas, I'm like, no, I'm just kidding. I'm just kidding. I'm just
You're
kidding. No, they
hilarious.
don't do that.
Yeah, that's funny because we do the same thing with all of our Georgia patients. We're like, yeah, you're doing way better if you just come see me here in Nevada.
Yeah, they're all like, oh, I talked to him and he's just mean, old Dr. Stanley.
That's hilarious. So real quick, shameless plug, tell everybody the phone number to call your office.
Yep, so you can call 706-974-7115. That's our 3-on-6 specific phone number. And then the actual office number is 706-265-6877.
Perfect. And then if you'd like to reach me here in Las Vegas, you would call 702-710-9006.
Did you read that off of a sheet? Tell me you read that off of a sheet.
No, I know it.
Oh, you know your phone number? You looked like you were reading. You were like 70.
I
didn't say it slow because I have a tendency of speaking too fast.
I might have been in the background 7.
No, she was not.
That's good.
Okay,
that's good.
So we have had a question, and I think this is a thing worth addressing. So Dr. Stephen, or not Dr. Stephen Strong, somebody named Stephen Strong just said, hey, Dr. Emett and Stanley, would you have time to talk about your individual processes for the 3 to 4 month visit and what to expect for us as patients that have been waiting to reach this milestone? So
no, that's a very, very well-kept secret. We will not talk to you about.
No, we are not disclosing what happens at your 3-month appointment. We're never going to do it.
No, demystifying that is really, really important because for 3 months, patients will work themselves up into a frenzy of what to expect because at that appointment, you're not going in sedated. So you're like, what am I going to feel? What am I going to see? So yeah, Dr. Emett, I'd love to hear what you guys do. And I'll chime in as well about how that 3-month appointment goes. Yeah.
So first off, at the beginning of the onset of treatment, I tell patients this is a 6-month thing. I like to underpromise and overdeliver. Oftentimes we can be completely done in around 4 months. That's totally fine. Sometimes I'll place implants and I'll say, hey, that patient needs an extra month to heal, depending on how the torque values are. I think there's a little bit of flexibility there, but we're going to just assume that your 3 to 4 month appointment is your second set of temporaries appointment. So there's a little bit of a difference here in my office for my out-of-state patients versus my in-state patients or my local patients. So if you are local to my office, you're going to come into the office. We're going to take the bridges off. This is a really strange feeling to have your bridges out, but we're going to take you. Well, first off, we're going to take an x-ray. Then we're going to take your bridges out, and then we're going to test every implant. We do that in a couple of different ways. One of them is the old school tap test. It's a percussion test. And I can tell you that most of the time, I'm not like trying to make voodoo science up here, but I can diagnose an implant by tapping on it. I can hear the sound of an implant and you just know how that implant is.
He's watched Pitch Perfect, the movie, quite a few times. He knows that sound.
You know, you do the same thing. So first thing I'm going to do is we're just going to test every implant. We're going to give it a little tap test. And then we're going to do the torque test, like Dr. Stanley mentioned earlier in the live today. We're going to test every implant. Once the implants are tested, we're going to take some new scans. We're going to get those scans done. And then if you're local, well, even if you're not local, we're going to put those bridges back in. The same ones we took out, we're putting right back in. As long as all the implants are happy, integrated, and done, the biggest challenge of implant dentistry is over with. Your implants have osseointegrated and you're ready to move on. The next part of that appointment is the fun part, in my opinion, because we are just going to talk about your teeth. We're going to talk about what you do like about your teeth, what you don't like about your teeth, because this is an opportunity now to make any cosmetic or functional adjustments. This is going to be the time where we get your bite socked in perfect. I'm going to tuck your new set of teeth up into your gums and close off any open spaces. And the cosmetic outcome is going to be decided today. Then we take all that information, send it to the Amazing Lab. The Amazing Lab takes about 2 weeks. They're going to get us the files back. We'll have you come back in a couple of weeks. And the next appointment, we take your teeth out again and we just put the new ones in. And this is the aha appointment. Like the patient yesterday who just could not stop smiling. Like she was just over the moon about how her teeth looked and how they fit and how her bite felt and how it looked. So that 3 to 4 month appointment is the opportunity to test all the implants, make sure your healing is complete, and move on with the cosmetic steps. Dr. Stanley.
Yeah, that's the same. Out-of-state patients have the opportunity to, I think the lab has a very, small, basically they need to have someone in there designing the teeth same day if you're going to have that delivered the very next day. So for an out-of-state patient, we would do the same thing. Take the first temporary off, the healing teeth, take those off, test each of the implants. I don't do as much tap. I torque test, and if it torques, we're good. We've used in the past. There's machines that can test the integration, give you a concerted value. I don't love those.
I don't either. I just feel like it gives you some arbitrary number. Oh, that got a 63.
Yeah,
and it's like it doesn't mean anything.
Yeah, it's supposed to be bone to contact value, and it's not out of 100. It's not a score. It's not a percentage. So it is arbitrary. However, I've used them in the past, and if an implant is ailing, and I do distinguish between an ailing implant and a failing implant, and so we go in that direction. But yeah, out-of-state patients can get their temps the next day if they decide to, and we need to know that when you have your surgery. And if you're coming back from North Carolina in 3 months, we would just schedule it for the next morning, and we would have you in the same day, scan them in the afternoon. The lab designs it, they get it to us, we print your next set of temps, and those are divided into bridges, because the first set should be one full arch that supports all of the implants. Then the second set would be the aesthetic teeth. So I talk about it as your healing teeth, your smiling teeth, and then your finals are your chewing teeth. So we get the aesthetics dialed in with your smiling teeth. That's the second set of temporaries. And if there's any changes, a lot of times isn't it amazing to you how 1 millimeter difference makes all of the difference to a patient? They're like, oh my gosh, my teeth feel like horse teeth, and we move them by 1 millimeter.
Right.
We're talking 1 millimeter, and they're like, "Oh, this is perfect. This is
perfect. This is just how I wanted him to look. This is exactly what I wanted." Yeah, these are small, minor adjustments.
Yeah, the lab is doing their very, very best on same day to get all the information that we're getting, and they're overlaying first scan with second scan and the proposed scan to try and get all of those values to meet up. And it's remarkable how well they do it. But occasionally we'll have a patient comes in, and at the end of surgery, I'll look at them, and from their eyes to their mouth to their nose, that is where we determine things. But it's a little off, or one's too long, one's too short, they're too far in, too far out. And I emphasize that these are healing teeth. We want the gums to heal. Once the gums are settled, then the next set go back in, and those are the smiling teeth, and they pop. They look good. Yeah,
that's really good. So we've had a couple of questions real quick. Just going to go back up through here. Joseph said, Dr. Oliveri is 5 minutes from me. Super lucky. You are super lucky. She's phenomenal.
That is. She's great.
I talked to her just the other day. You're in great hands. A patient posted on Instagram, best decision I've ever made. Did a lot of research and came across Dr. Emett, and hardest part is learning how to smile. That's such a compliment to their work, when the hardest part is going back out and actually having, just knowing they can smile again and allowing themselves to do that. That's the hardest part for this guy. Dude, congratulations. That's amazing.
Yeah, that sounds awesome. I don't know if you guys do the same thing, but whenever I'm talking to patients at the end of their surgery, and I tell them for the next 3 months, one of your only jobs is to stand in front of a mirror, and just like an actor or an actress, is learn how to talk and learn how to smile. So a lot of patients are in the habit, and I find this sometimes in my middle-aged female population, where if you're wearing cheater glasses, that's a habit that people do. But then they wear the glasses, and they look over their glasses to talk to you. So if you look at my smile, I smile and you see my teeth on the top row. But if I look down, you
Yeah.
see my lower teeth. And I've had a few patients say, gosh, I only see my lower teeth. And that's that habit of covering up your uppers and looking down. And, you
That's
know,
very true.
that's so there's a lot of posture, there's a lot of muscle memory and exercising your cheek muscles to get those guys nice and strong so that chronically and at rest they are higher on your face. We see that a lot with we know that as we hit 40 years old, like
Yeah.
I just am there, everything starts to do a little number heading south for the winter. But as we age, that just is a normal progression. So we try to transition the smile to be a little lower in the view so that it comes into view, so that that upper lip doesn't cover your upper teeth. So yeah.
Good point. Glad you brought that up. Mia Huff said, what do you mean? Does it hurt to get that done at 3 months? The 3-month appointment is a pain-free appointment. Sometimes taking the bridges off can be a little uncomfortable, but you're not getting numb. It's not a painful type appointment. She says, taking my teeth out sounds painful.
So I will say this, when the implants are deep and the tissue is thick, then, in those cases, when the abutments, and the distinction is between implant, which is in your bone, abutment is the connector piece, and sometimes they're in one piece, sometimes we screw them in, and then the teeth are on top. That abutment can get loose, and I have had patients, like quite a few patients, as I'm tightening that down again to verify that it's fully seated and integrated, that it can pinch the gums a little bit. It's not like getting an injection. It's not like getting a tooth removed. I have found a couple patients that it was more comfortable for them to get numb on one spot than others. Or if I'm going to change the angle of one of the connector pieces to make it come out in the right spot. So to your question, if you're really worried about that appointment, I've had a couple of patients where they're so anxious that we just did some moderate conscious sedation for that appointment and made sure that they had someone there for the aesthetic check. Because if you if you put teeth in and then ask how does it look, and someone's a little high on some sedation medication, they say, "Oh, it looks great, doc." Then the next day they might not agree. So that is an option at my office. We had sedation medication where you can, like a chill pill, think about it like a chill pill. And, even Valium or Ativan is a medication that people take from their doctors, and that just relaxes you a little bit. So consider that if you're really anxious and And
I can tell you that in 2 years, I've never done that. I've never given a patient any kind of sedation at all for a 3-month appointment. I rarely have had to get a patient numb, even in a local spot. Most of the time, getting numb is worse than just let me tighten down a little abutment. It takes 2 seconds and it's over with. And so anyway, that's good. I think that's some different perspective there to have. So that's good to talk about.
Yeah, I think it can be tailored to whatever the patient is. If you're really concerned about your 3-month appointment, then just talk to your provider and let them know those concerns and ask, is there anything that can be done to help me a little more, whatever. But I think in the end, it's very different than the traumatic experiences that patients have had that created their dental phobias.
Yeah.
That's the vast difference, is we're not usually in a torture session that is, patients, I've heard stories, so many stories, knee was on my chest and they're pulling my tooth out and there's just trauma. And so we're not doing that. We're trying to make it as easy as possible.
Yeah. Mia Huff, that sounds not sounding so bad. I was worried about that too. All right, cool. Okay, so I just got
you can do this, Mia.
Yeah, you can do it. I've got some random questions here. I just kind of want to go over real quick. We're going to get these. We have 10 minutes left. So each one of these questions, you have 30 seconds to answer it. And I'm just going to give you some quick fire questions. Okay. You have 30 seconds. What is a guided surgery?
Guided surgery. So the difference between freehand and guided surgery, if we go in and we've planned the implants digitally in your bone and overlapped your teeth, gums, and your 3D scan, then we know exactly where we want the implants so that the teeth come out as slender as possible. A freehand surgery is more common with all on four. You just put the implant where the bone is, and the abutment comes up, and wherever it exits is where you make the teeth. And it's kind of less custom, and it can be done faster. And but custom, we would have literally an acrylic guide with sleeves, kind of like a pilot drill. When you're pilot drilling through into a piece of wood, it gives the space where that screw is going to go exactly where it needs to, instead of deviating into where it might be trying to go. Perfect.
Good answer. Why are there little holes in my teeth, in my healing teeth?
There's holes in your heel. Yeah. Okay. Never mind. The tiny little holes are access for us to be able to access the tiny little screws. So we want those to come out directly behind your front teeth and directly through the chewing surface of your back teeth, so that we can access those in the event that a bridge ever needed. If you get into a car accident and you break a bridge, we would want to be able to retrieve that without removing the implants from your bone. So you can access through tiny little hole, you unscrew, and then we fill those in at the end of your surgery. When you go into finals, we fill those in. Actually, Dr. Emett, let's say a plug for Dr. Emett. Dr. Emett is an innovator. So he was able to find us a wonderful material that helps us during the temporary phase, that in the past we were using other stuff that was just time consuming, difficult and to use, but he helped us get a great material to use for patients during that healing phase. So if it's a 2-minute thing to get the little stuff out of the holes, you can thank Dr. Emett.
Yeah, well, I appreciate that. It was yeah, thanks.
Dr. Emett rock.
I just got sick of digging the other stuff out of people's teeth, so there had to be something better. Okay, why are there so many sutures?
Why are there so many sutures? Well, so when you think the old adage in dentistry is the bone sets the tone, but the tissue is the issue.
Yes.
The tissue, that gum tissue, we want to hold it exactly where we want it for as long as we can, until it, 1, bonds to your bone, and 2, connects from tongue to cheek side and seals over the bone. So we use sutures to hold it in place, and then I actually use some Elmer's glue. No, I'm just kidding. It's some tissue glue, and that glue holds it in place, and it's a little goopy afterwards, and kind of annoying to click off, but way better healing than what I've that's just the progression of technique in surgery. So
yeah, and we do the same thing: sutures and tissue glue. Elmer's glue works perfect. Okay, how long do the plastic teeth last?
So the plastic, or more correctly, the resin teeth, how long can they last? That's actually a good question, because
I was kind of excited to have you answer it for me.
I think the real answer is long enough.
Long enough.
The long enough is the answer. I have had a patient where one set of temporaries, without breaking that set of because that's what happens. If you start chewing on these temporary teeth after the 3-month appointment, they're meant to be functional. They're not meant to bite into a corn nut or a crouton. If you bite into a crouton, it's all on you. You should not be doing that. So, but I think long enough is the actual answer. I've seen of patients, and I've heard of patients on the Sprint Ray, not the 3-on-6 group, but the Sprint Ray, that patients have been in full arch temps for multiple years without them breaking. So that's when it's really thick and it's one arch. So it's a little different than our 3-on-6 stuff, but yeah, they're very durable. I've also had a patient that broke 4 sets. His was upper 3-on-6 and lower teeth. Those are, I think, what I've realized are the most difficult for patients to adhere to our instructions, is when you do upper 3-on-6, you've got these beautiful teeth, and after a couple months, man, these feel great. These feel like I could do whatever. And your lower teeth are your natural teeth, and you're like, I'm going to go bite and chew whatever I need to chew.
Yeah. My case on Wednesday is that exact case. Upper 3-on-6, lower natural dentition. I did one little bridge here in the front, and I was like, you have got to stick to the soft food diet, or you will start breaking these bridges and start having problems. So
Yeah, I drill that. So I'm sure that all my patients are so tired of me saying, if you cannot squish this through a fork, it does not go in your mouth.
Yeah, and I always say, if you can cut it with a plastic fork, not a Costco one, I'm talking a cheap plastic fork from a Mexican restaurant. If that will cut your food, you can eat it. But if you
Yeah,
can't cut it with a plastic fork, you can't have it.
I love how different areas of the country, it is. When people hear, if you can't squish it through a fork, you can't put it in your mouth. That's how we in the
That's
South.
how you say it.
That's
That
my
nice
people.
plain. Yeah, you
Yeah,
sound good. Listen, we've only got a couple minutes left here. So what I want to do is have you just give out your phone number again real quick. If somebody has any questions, they want to schedule a virtual consultation, they're on your side of the country, Dr. Stanley, how do they call your 3-on-6 office?
Yep. So if you saw this, and even if you see this in the next few weeks, we're going to monitor this thread. We're going to answer your questions.
Yeah.
If you would like to call and discuss this, we have a specific coordinator at Timber Ridge Dental Center in Dawsonville, Georgia. You can call at 706-974-7115, or you can call the office directly to 706-265-6877. And we'll post here in the link of this section the information there as well, and happy to answer all those questions. If you're on the West Coast, love for you to call, go see Dr. Emmett. I want to see your pictures afterwards. I love seeing everybody smile standing next to him because he's got such a good smile.
Dude,
He's
you're
just a happy guy.
All right. And if you are trying to get in touch with us here on this side of the country in Las Vegas, of course, you can always get me at 702-710-9006. Okay, so it's Halloween today. You have some kids, Dr. Stanley, yeah?
Oh, so many kids.
It's so many kids, like 30 of them. This guy's got
we've
so
got
many
like
kids.
just tons of kids.
What are they dressing up as today?
I mean, we've got Iron Man, the classic Iron Man, except for he thinks he's Iron Man, but he's wearing a ninja costume. We don't tell him that it's not an Iron Man.
It sounds like Iron Man to me.
He's Iron Man to me. And then we've got Toothless. Toothless is the dragon, except for I did not extract the teeth. I left the teeth in there, so we're good to go. And we got a Grim Reaper and a skeleton, so we're all going creepy. My 7-year-old thinks his is the creepiest. He's got a swamp mask and a green suit with these claws. He's not as scary as I look, but we are what we are.
That's awesome. Good for you, man. Well, I'm super excited for you to go trick-or-treating tonight. Hope you get some good candy out there. It sounds like it's gonna be a fun time with your kids. Everybody that joined us on this call today, thank you so much. As always, we love our jobs. We love helping you guys get new smiles. Love helping you get your 3-on-6. Any questions at all, don't hesitate to reach out to us, and we will see you next time.
All righty. Bye-bye.
All right. Thanks, Doc. See you later.
Yeah. See ya.
Bye.
Bye.